Hello, everyone. I'm Stephanie Maselli, Media Officer with the National Academies of Sciences, Engineering, and Medicine. Thank you for joining us today for a public briefing for the recently released report, Guiding Cancer Control, A Path to Transformation. We usually get this question, so I'll answer it outright. The slides and recording of this webinar will be available next week at www.nationalacademies.org/cancer control. You can download a copy of the report there as well. For those of you who are not familiar with the National Academies of Sciences, Engineering, and Medicine, we are private, nonprofit institutions that provide independent, objective analysis and advice to the U.S. to solve complex problems and inform policy decisions related to science, technology, and medicine. For each requested study, panel members are chosen for their expertise and experience, and they serve pro bono to carry out the study statement of task. The reports that result from the study represent the consensus view of the committee and must undergo external peer review before they are released, as did this report. I have with me several members of the committee to discuss the report. But before I introduce them, I want to go over a few reminders. Please note this webinar is scheduled to last 1 hour. We will start off with a presentation summarizing the report by the committee members, and then I'll open it up to any questions you may have. You can simply click the Q&A button on the bottom of your screen to submit a question. And if you have any technical issues during this webinar, please contact Zoom technical support. That number is 1-888-799-9666 and select option 2. And now I'd like to introduce the members of the committee that wrote the report who are here with us today. First, we have Michael Johns, the committee chair. He is the Executive Vice President for Health Affairs and Chancellor Emeritus at Emory University. We have Ashley Guadagnola, Professor of Radiation Oncology and Health Services Research at MD Anderson Cancer Center in Texas. We have Joseph Lipscomb, Georgia Cancer Coalition Distinguished Cancer Scholar and Professor of Health Policy and Management at the Emory University Rollins School of Public Health. We have Mary McCabe, who is an oncology nurse and medical ethicist and former clinical director of survivorship at Memorial Sloan Kettering. We have William Rouse, Alexander Crumey Humphreys Chair and Director of the Center for Complex Systems and Enterprises at Stevens Institute of Technology. And with that, I'll turn it over to Dr. Johns to kick off the presentation.
Well, thank you. I'd like to welcome everyone to this report released webinar of the new National Academies report. I serve as the chair of the ad hoc committee on a national strategy for cancer control in the United States. And I believe we have produced a report that we hope will serve to reduce the incidence, morbidity, and mortality from cancer and to improve the quality of life for cancer survivors and bring about changes that will not only improve the overall productivity of the nation and the lives of countless families like mine, but also can set a precedent in the control of other diseases. So this slide represents the sponsors of our study. And we would like to thank them, the sponsors, the American Cancer Society, Center for Disease Control and Prevention, and the National Cancer Institute of the National Institute of Health. And we always like to also add this disclaimer that any opinions, findings, conclusions, or recommendations expressed in this publication do not necessarily reflect the views of any organization that provided support. So listed on, let's get the slide to go. Listed on slide 3 are the committee members who volunteered for this study. The 16-member committee was intentionally composed of individuals with diverse professional backgrounds in such areas as oncology, public health, health services research, healthcare delivery, patient advocacy, health economics, epidemiology, program evaluation, prevention, health disparities, treatment, survivorship, quality, and systems engineering. The bios of the committee are included in Appendix B in the report. And I want to say that this diverse group of individuals really brought about, I think, multiple perspectives and views that really led to some of the recommendations that you're going to hear about today. Mary, you want to speak to this slide here?
Yes, and so this next slide actually shows some historical landmarks that highlight formal policy over time that have been focused on reducing the cancer burden in the United States. So beginning back in 1921, the U.S. Congress requested the National Academy of Sciences to provide advice to the federal government for developing a successful and practical cure for cancer. And then 9 years later, during the presidency of Franklin Roosevelt, the National Cancer Institute was established by the U.S. Congress, and it was primarily focused to show the useful application of results. During World War II, unfortunately, NCI's efforts were scaled back for economic reasons, but quickly after the war ended, there was funding reinstituted to lead to the expansion of the national cancer control efforts. And it may be familiar to many of you, the effort beginning in 1971 by President Richard Nixon, when he signed the National Cancer Act and signaled the beginning of what was termed the War on Cancer. This act widely increased research on the biological basis of cancer with the expectation at that time of finding a cure. And we've come many decades since then. In 1998, the CDC began a pilot program to promote a more comprehensive approach to cancer control across state, territory, and tribal administrations. And in that program, CDC initially funded 5 states and 1 tribal health board, each of which had already established a cancer control plan for its own jurisdiction. And over time, cancer plans have since proliferated, and today all 50 states and the District of Columbia, 8 U.S. Pacific Island jurisdictions in Puerto Rico, 6 tribes and tribal organizations have cancer control plans in place. In total, there are 65. Each plan has a local focus with whatever differences are necessary to meet local needs created by the cancer burden. Several more administrations and many organizations, including the American Cancer Society and other professional organizations, and even individuals, have continued to commit for this conquest of cancer. Although the U.S. declared a war on cancer, and that's a nomenclature that has been used repeatedly over many decades, and our effort began 50 years ago, we've seen certainly progress in individual components of cancer control, such as declining death rates for certain types of cancer. But we know that these diseases that we cause cancer continue to take an enormous toll on patients, their loved ones, and societies.
So this slide depicts the trends in cancer burden, and it shows age-standardized death rates among males and females in the United States from 1930 to 2015. These data are drawn from the National Center for Health Statistics. And what we see here is that since the 1990s, deaths from cancer have declined on an average of 1.8% every year for men and 1.4% every year for women. And while death certainly gives rise to the greatest fear and loss associated with cancer, the burdens of cancer are broad and diverse, and they range from the physical, financial, and psychological tolls on patients, their families, and caregivers, as well as the cost inflicted upon the nation's healthcare infrastructure and public health system. The next slide shows the estimated cancer prevalence by age in the United States population from 1975 and projected out to 2040. Cancer control efforts face an enormous and vexing challenge due to the rapidly growing numbers of older people in the United States. By 2040, the number of people in the United States aged 50 to 64 years with cancer is expected to be 4 times the number it was in 1975. The projected growth in the number of cancer cases is even more dramatic in the older age groups. There's a 6-fold increase projected in the age group from 65 to 74, a 10-fold increase for age 75 to 84, and a 17-fold increase in the over 85 years of age cohort. This is largely due to rapidly increasing numbers of people in the older age brackets and not necessarily to increases in the cancer incidence rates among them. However, concomitant increases in obesity rates are also expected to contribute to an increase in cancer diagnoses. In a recent report from the American Cancer Society that was released a couple of weeks ago while our report was in press, it was estimated that the number of cancer survivors in the U.S. is set to rise by more than 5 million by 2030. The current cancer burden varies by type, distribution, and weight, and does so by different demographic factors. For instance, there are important differences between men and women in the types of cancer that they are likely to die from. Prostate, lung, bronchus, and colorectal cancers account for 42% of all cases of cancer in men, with prostate cancer alone accounting for nearly 1 in 5 new diagnoses. For women, the 3 most common cancers are breast, lung, and colorectal, which collectively represent 1/2 of all new diagnoses. Breast cancer alone accounts for 30% of all new cancer diagnoses in women. And for both genders, deaths are attributable to lung cancer in approximately 1/4 of patients.
In addition, there are significant disparities in cancer incidence and outcomes that persist across different populations.
Need to go back one.
You need to go.
Oh, there you go.
Right. Cancer disparities, indeed, they persist across different populations. These disparities include variations in racial ethnic status, socioeconomic status, and by geographic location of residence. Such disparities have been identified in a variety of published analyses that inform the work of the committee. To illustrate here, we see the trends over time in mortality rates for breast cancer, prostate cancer, and colorectal cancer by racial ethnic status. What we see is a persistent tendency for Black rates to be higher than for all other groups, even as the rates for all 3 cancers are trending down over time. Such trends no doubt reflect underlying variations, indeed underlying disparities across populations in multiple factors that are amenable to change and improvement via better cancer control efforts. In particular, we have disparities now in access to and embrace of primary prevention activities related to diet, exercise, and smoking. We have variations in access and utilization to early detection and screening, which in turn leads to variations in stage of diagnosis. We have variations in access to and utilization of guideline recommended cancer therapy. We have variations in appropriate care during the post-treatment survivorship period with respect to surveillance screening and other such activities. So by implication, reducing disparities in cancer incidence and outcomes can and must be a major focus of a transformed cancer control enterprise in the U.S. One of the important areas that the committee looks into in order to develop a broader understanding of the cancer control enterprise is the social and economic costs that are associated with cancer. Cancer inflicts significant financial pain on patients and their families, as well as on public and private payers. And those public and private payer costs are ultimately borne by individuals, families, private sector firms, and taxpayers. Based on an evaluation of currently available data, we believe that a reasonable order of magnitude estimate for the current total annual economic burden of cancer in the U.S. is approximately $600 billion. This breaks out as follows. Direct medical care costs, approximately $173 billion a year based on published estimates. Productivity costs, sometimes called indirect costs, from premature cancer-related mortality and cancer-related loss of productivity at work and at home, coming to a total of $357 billion. About $308 billion of that related to mortality cost, and the other $49 billion estimated to be related to morbidity costs. But there's also spending on government research on cancer, plus cancer control implementation nationally and at the state level, and we estimate that to be about $8 billion a year. Biopharmaceutical sector investment coming to $30 billion a year. Spending by cancer-related nonprofit organizations in total estimating coming to about $3 billion a year. Spending on workplace wellness program for cancers and other diseases coming to roughly $8 billion a year. Complementary and alternative medicine expenditures related to cancer coming to $4 billion a year. And all of this adding up to roughly, by our estimate, $583 billion, which in some sense we regard as conservative because it does not include expenditures for early detection and screening, and also spending by individuals and families on their own cancer prevention activities. So we think $600 billion is a reasonable benchmark to gauge the enormity of the problem. But this figure is going to grow over time in response to population growth, which is going to in turn significantly influence both the direct and indirect cost burdens of cancer and other factors. But beyond these aggregate estimates, which are undertaken largely from what the economist calls the societal perspective, there's the cost burden felt by individuals and families, the financial toxicity of cancer. Multiple studies, including those supported and conducted by our sponsors, have demonstrated the importance of this and the growing importance of this. In sum, this underscores the idea that a major challenge of cancer control is cost control, most especially for those who do bear the burden of the disease.
So the leadership of the National Academy of Sciences, Engineering, and Medicine initiated this consensus study to examine cancer control efforts in the U.S. and to recommend a national strategy to reduce the incidence, morbidity, and mortality from cancer, and to improve quality of life for cancer survivors. The committee was also tasked to review trends in cancer cases and outcomes in the United States, as well as existing cancer control programs and initiatives across the cancer care continuum. And then, of course, to issue a report with findings and recommendations to achieve progress in developing and implementing national cancer control strategy. The resulting consensus report, Guiding Cancer Control, A Path for Transformation, presents the committee's strategic vision and its recommendations defining the key principles, attributes, methods, and tools needed to achieve the goal of implementing an effective national cancer control plan. During its year-long deliberations, the committee received presentations from individuals representing themselves or specific organizations. We received inputs from members of the public. We reviewed several thousand pages of documents and benefited from written submittals provided by individuals and organizations. The committee's draft reports were then subjected to an in-depth review by 16 anonymous reviewers and 2 overseers, and the committee provided then specific responses as to the disposition of each of the reviewers' comments. This report starts with the complexity of cancers and cancer control, and then it works toward motivating an approach that seeks to better understand, develop, and improve both our current and our planned efforts. It promulgates a wider conception of cancer control, starting from basic risk awareness through end of life, involving a range of participants much broader than usually considered, and it advances the national strategic vision for cancer control. Throughout the report, a distinction was made between the process and the system of cancer control. Process refers to what happens and how. That is, to those actions that are taken in cancer control efforts, while system refers to the collection of entities and organizations that carry out the process. The system of cancer control in the United States is extremely complicated in the sense that it has a large number of components connected in various ways, maybe not connected as well. But it's more than just complicated, it is complex, because the overall performance of the system cannot be understood in terms of the behavior of the individual entities in isolation, but rather is inherently the product of interactions between the different entities.
So this next slide depicts the process of cancer control. And the continuum that's shown here consists of half a dozen steps in the cancer control area that we've historically thought follow one another in a linear fashion. So we have prevention, screening, diagnosis, treatment, survivorship, and hospice care, with palliative care and supportive care cutting across these steps. Now, there have been certainly successes and tremendous advances in each of these components. So if we take, for example, prevention expanded certainly our increased awareness of various health-related behaviors that can be modified to reduce cancer risk, and include advances in chemoprevention, immunization, and prophylactic surgery. such as mastectomy in women at high risk for breast cancer. Components of screening now benefit from significant advances in genetic testing for high-risk relatives. And similarly, technological advances have also changed the profile of diagnosis to include improved imaging technologies and laboratory tests such as molecular profiling and biomarker identification. Surgery, radiation therapy, chemotherapy, targeted therapies, and immunotherapies have all played a significant role in advancing life-extending treatment. Treatment coupled with the next block in our continuum titled survivorship. This is a topic that's garnered greater and greater attention and appreciation in recent decades as, fortunately, the number of survivors have increased. The survivorship period also includes health services such as surveillance for recurrence, with attention to acute and chronic medical and psychosocial effects of treatment, which can impact a patient's quality of life, despite the fact that they may have been successfully treated. The next area, this continuum component, hospice care, is known that we need to provide the greatest benefit by earlier options for patients that are discussed in conjunction with their families and their healthcare providers. So we've made advances, but despite the ideal in these various steps and how they should be connected, in practice it's often the case that the specialists focus on their own components separately with little connectivity between the various sections. Each component of the continuum involves a wide range of participants, including patients, families, caregivers, communities, clinicians, researchers, health systems, and insurers. And the dilemma that we face as a nation is that the contributions of these different constituencies are typically not well coordinated and may have widely varied incentives and conflicts of interest.
We tend to think of cancer control in terms of clinicians and patients and their families interacting, agreeing what to do, conducting those treatments or interventions and following up. But the system is much more complex than that. Those agents, clinicians, patients, et cetera, utilize processes or operations that are owned by organizations, by providers, by payers. Organizations include pharmaceutical companies, medical device companies. There are an enormous number of organizations that invest or don't invest in the processes that the cancer patients need. And those organizations all operate within a framework provided by society. What does society care about? What is society willing to pay for? How does society recognize success? This society includes Congress, for example. It probably includes many of you online today, where you're playing a role in nonprofits and in research institutions. The whole system is a system that creates cancer control. And it can create surprises when you don't pay attention to all the levels. A good example is opioid abuse, which is a different area than cancer, but is illustrative. The opioid epidemic was detected at the agent level. We had a dramatic increase in overdoses and deaths that has continued. At the organizational level, they decided the key is to prevent opioid use by limiting prescriptions, both in terms of number of pills and number of refills. So they did that. And the data from Indiana and Kentucky indicates that the number of overdoses and deaths increased, which was certainly not their intention. It increased because the agents at the lowest level resorted to street drugs, which are much more lethal than prescription drugs, which they could no longer get. So in this case, we see the organizations implemented a strategy that made things worse, which was certainly not their intention. And that's what can happen in a complex adaptive system like this, with multiple levels and multiple agents acting in a variety of ways, often well-intended, but not in a coordinated way. And this model leads us to the conclusion in the next slide, which is fairly straightforward. The system of cancer control that currently exists in the United States has developed over time, not under the direction of some master plan, but rather piecemeal as a result of thousands of participants in their decisions. In other words, the system of cancer control in the U.S., indeed, the whole system of healthcare in the U.S. was never designed. It just emerged from various players being motivated to pursue various goals, having resources, having jurisdictions, and things were not coordinated. Information was not shared. And basically, the complex adaptive model we just showed you basically implies that we need much greater coordination and much greater information sharing if we're going to make a major impact on cancer control. Now, the next slide shows a version of the complex and adaptive system. I won't go through in detail, but this is cancer. Cancer itself is a complex adaptive system. It adapts to interventions we try to thwart it. It convinces the immune system to help it. It's a complex adaptive system in itself. And so you can see that this way of thinking about complex adaptive systems runs all the way from biology to society. It runs from cells to Congress. And we need to understand how all those things link together in order to make the most effective investments in cancer control. Now let's put it more down to earth. If we just look at what is this cancer control approach, how does it really differ? What does it cause? How does it cause us to think? How does it cause us to reframe the problem? Okay, first of all, complex adaptive systems are nonlinear and dynamic. They don't respond always in predictable ways. They're composed of independent agents. In the cancer control system, there are millions of independent agents, we could argue, all trying to do a good job, but not in a coordinated way that where information is shared. Because the agents have different needs and desires, often their needs and desires conflict. The provider wants to spend more on your care, the payer wants to spend less. There's an inherent conflict in the system, and we need to understand the implications of that before we actually roll a policy out. The agents are intelligent, they adapt and evolve as the rules of the game change. They learn about the environment, they learn about the new rules, they find ways to game it, to work around the rules to their betterment. Okay? There's no single point of control. As we learned with the Clinton plan many years ago, there's no one you can just go order to fix things. The system doesn't work that way. It's a distributed set of agents. Okay? The healthcare system is a federation of millions of entrepreneurs with no one in charge. No single entity can command change. Now, what this means is you cannot command and control this system to do anything. You have two levers. One is incentives. You try to incentivize behaviors that will cause the agents to better the system. And the other is information sharing, the information they need in order to execute their strategies that they've adopted because of your incentives. So incentives and information replace orders in command and control.
Good, thank you, Bill. So this report offers 3 interlinked recommendations supported by 10 conclusions and 25 findings, all based on the overarching message that an imperative is to overcome the current coordinated approaches that constrain progress and effectiveness across the segments of the cancer control continuum. This is an imperative. These findings, conclusions, and recommendations are discussed in detail in the committee's report. But because of the time, we'd just like to highlight some of the conclusions and all the 3 interlinked recommendations. So the overarching conclusion: the nation's cancer control system will need to become more effective, efficient, and accountable than it is today if it's to successfully address the approaching wave of cancers in our aging society. Successful national cancer control efforts will require significant integration of resources and a major collaborative initiative among multiple participants to develop a joint ability with joint accounting and accountability. So, what are the features of this national cancer control strategy? As the committee was charged with developing a national strategy for cancer control. So, therefore, the recommendations of this report define the key principles, attributes, methods, and tools needed to achieve the goal of implementing an effective national cancer control plan. And even if this exercise is actually possible within the scope of the study, and the lists were included as part of this report to monitor and guide the national cancer control system in desired directions over specific time ranges, it is very likely that those specifics may not be accepted across the variety of stakeholder groups. The recommendations, therefore, will inherently require joint action and resources with the support of a systems monitoring and planning tool to track the state of cancer control efforts and the resulting changes in health. Stated in a highly abbreviated form, the recommendations proposed by the committee are as follows. First, the committee recommends a strategy to ensure integration of resources and coordination of operations across the various components of a national cancer control system. A national plan should improve the availability of preventive, screening, diagnostic, therapeutic, and palliative interventions, as well as survivorship care, hospice care, and social services according to patient and family preferences and values. It should leverage scientific advances to improve therapies and better understand their scientific, clinical, and economic impacts. It should integrate a broad range of data sources by integrating the use of social, behavioral, and other information made possible by the convergence of communication, social media, cognitive, financial, and other technologies. It should use and evaluate advanced technologies for continuous analytics, rapid reporting of trends and patterns, and improved forecasting and performance reviews. It should apply the tools of complex systems analysis for assessing the value of cancer control interventions, guiding the development of products and services, and developing new payment mechanisms, and finally, helping patients make informed decisions. Now, the features of a national cancer control plan include minimizing waste and harm stemming from disparate clinical practices, interventions lacking evidence of effectiveness, and conflicting clinical practice guidelines. Should track and monitor financial links, incentives, and disincentives throughout the processes and systems of cancer control, and rigorously require conflict of interest disclosures across cancer care research and patient advocacy activities. It should expand and support reproducibility strategies for developing reliable evidence from research. It should discourage direct-to-consumer marketing of clinical products and services and tighten and enforce rules to curb promotion of non-evidence-based products and services. It should launch and expand public engagement and outreach to broaden the understanding of cancer prevention as an integral component of a healthy life course. The department, so this is an important recommendation right here, and this addresses the governance of a multi-agency U.S. national cancer control plan, our strategy. The development of the Department of Health and Human Services has been the lead agency within the federal government with numerous constituent units interested in cancer. But across the U.S. government, cancer control efforts are situated in a wide range of agencies reflecting the very broad nature of cancer control. Coordinating a wide range of federal agencies active in cancer control efforts could require congressional action if the participating agencies lack a legislative authority, in which case it is urged that the U.S. Congress provide the direction to implement Recommendation B. And that statement here is, I don't want to, you all know these organizations, so I don't need to articulate the DOD, et cetera, fully, but the Government Accountability and Office should periodically review and report to the relevant congressional committees about the achievement of the goals specified in this plan. And the activities of these federal agencies, by the way, specifically apply to cancer, are described in Chapter 2 in the report. So in support of a U.S. National Cancer Control Plan, HHS and the federal partner agency should fund and support an independent organization or a consortium to prototype and develop a planning and monitoring tool that is publicly available, evolvable, and customizable across contexts and organizations. So the report recommends a dynamic dashboard, as envisioned in this report, which would incorporate computational models, data feeds, visual analytics to reflect the current state of cancer control efforts and to simulate how the system would respond to various changes and pressures. As an example, I guess federal policymakers could use the planning and monitoring tool to predict which range of outcomes are possible through treatments. such as immunotherapies, versus prevention efforts, such as HPV campaigns to encourage people to get HPV vaccines. Another potential use could be to access which policies would have the best chance of reducing disparities in cancer outcomes among various groups. Periodic consultation should be done with state and local governments, nonprofit organizations such as ACS, ASCO, etc., and leaders from multiple sectors such as biomedical, consumer products and services, computing, information technology, financial, transportation, agriculture, and construction to ensure that data feeds to the planning tools are customized and routinely refreshed. So the use of science and engineering of complex adaptive systems offers possibilities for new progress in guiding the cancer control system that will reduce the burden of cancer for individuals, families, and society as a whole. So if you want to learn more about the committee and to access the report and get in-depth reading, it's available on the NAS website at www.nas.edu/cancer control. So thank you.
And with that, we will now open it up to questions. Thank you to all the presenters. As the questions start rolling in, let's just kick off with this. What's the takeaway message of your report?
Well, I will start if you like, but you know, I think the challenge of cancer control starts with the complex nature of cancer themselves. And that cancer control has multiple levels of activity with multiple players engaged. And that it's been somewhat hampered by the lack of integrated resources or uncoordinated activities and conflicting interests and incentives. Others want to comment?
Well, you know, we talked earlier about if you had to put it just in a couple of words, we're basically arguing that you should think differently and play together.
That's right. Others want to comment on that? Well, it's clear that the breadth of cancer control is enormous.
Yeah, I think you could also say that we have done extensive analyses about the effectiveness of particular cancer control interventions within different parts of the cancer continuum, in the prevention area, in the screening area, in the treatment area, and survivorship as well. What is less common, in fact, what is rare, are modeling efforts, simulation efforts that attempt to link these different portions of the continuum and take into account and try to model the specific interactions between the different levels of the continuum, so as to enable one to be able to say, we initiate a policy X, let's say in the cancer screening arena, what impact might that have downstream in the cancer survivorship arena, just to give one particular type of example.
I think also in the committee's work, in the early part of the committee's work, it was clear that the burden of cancer falls heavily on certain parts of the population, whether it be certain vulnerable populations, whether it be certain regions of the country, whether it be patients experiencing cancer at the end of life who get suboptimal care. And the question became, how do we lessen that burden? And basically, we need to reframe how we think about it. There are no easy answers. It's a very complex problem, and so we need a completely different approach, and we need to bring in other disciplines, such as systems engineering and informatics, to solve these problems. And so this report attempts to use science from other sectors to apply to the cancer control problem.
We have another audience question. Can you comment on the role you see for current state, tribal, and territorial cancer control efforts?
Thank you for bringing that up. I noticed that on one of the slides that the Indian Health Services should have been listed as among the agencies that would need to be brought in, and certainly they would need to play a critical role as well in talking about what their constituencies needed, as well as what their challenges were. I think they would all be complementary and would certainly need to be included.
Yeah, and I think we clearly think of the state cancer control programs as an integral part of this proposal, that it's one of the layers in the system, and a very important layer that can drive cancer control at the state level, which has sometimes often varying needs from other locales. So they need to be a part of this, of the solution here.
I think they're also extremely important because they're at a level on the ground and geographic locations that specifically can address the needs of unique communities, which we need to maintain an awareness of and in addressing the problems of too. So I think we're not trying to homogenize the needs of patients and families and communities. What we are is really trying to identify how to, in a rather enterprise way, address the unique needs across the nation.
Thank you, Mary. Joe, you Alan?
Yeah, just in addition to that, I mean, there are plans in all the states and territories, and there's much to learn from. There's the question of where are the success stories in the different states with respect to particular types of prevention activities, promoting screening activities, and then to be able to take those best case results, understand why they worked, and to see whether or not one can then bring that to other arenas, other states, and so forth.
Our next question is, are you proposing an overhaul of current national cancer control strategies or blueprints, or is this plan meant to complement existing efforts?
So, it's Mike Johns. We're really asking, I think, to reframe our thinking and our approach to cancer control, and to take this wider perspective and to understand what each individual effort is and how it relates to others' efforts, and to really learn from the whole, as opposed to, our, sort of, I don't want to call it narrow, but our focus that's, has significant success in it, but there could be a multiplication of that success by taking a look and understanding how it relates to what other organizations are doing.
Yeah, Bill Rouse here. I think we're talking about how do we integrate what we're doing in a more efficient and effective way to achieve better outcomes, not how do we replace what we're doing.
Yeah, and this is a dynamic approach to cancer control. It's not static. It's not a reactive. It's not a approach that just follows the checklist, but it's one that's alive and that can evolve and respond to what we see, what we do, and the changes that might be necessary to improve and enhance cancer control.
We have another question that asks, a multi-agency approach to cancer control may seem daunting and heavily dependent on political circumstances. How do you propose making it a reality?
Well, we've talked about one way is by saying if you add up the projected costs of cancer and the projected costs of Alzheimer's, it's going to cost the whole GDP of the U.S. So we have to do something. We have to see this as urgent, and we have to dig in. And we're proposing an approach for how to do that to make this whole problem tractable.
Joe?
Yeah, this is Joe Lipscomb. I mean, there are certain aspects of the recommendations as well that could be political, but not necessarily certainly oriented that way. The recommendation, for instance, to build the planning and monitoring tool to be able to understand the cause-effect relationships both within segments of the cancer continuum and across the continuum. This calls for collaboration. This calls for scientists in federal agencies and in private cancer organizations and elsewhere to work together on the science of understanding cancer control, particularly from a data and statistical modeling standpoint. So politics, yeah, but this is the kind of activity that these individuals are great at. And the thing is to bring them together.
Ashley.
This is Ashley Guadagnola, and one point is that the multi-agency approach already exists. We are not proposing that agencies get involved. We point out in Chapter 2 of the report that that many federal agencies and state and local governments are already involved in terms of the policies that are set regarding food safety, environmental safety, urban planning, which allows for safe spaces, and or planning that creates situations where populations can access fresh foods. There's already the Department of Education is involved in physical activity levels for children in school. So there's already a cancer footprint in all of these agencies. What we're suggesting is that this needs to be more explicitly coordinated and laid out.
We have another question that asks, how will the proposed national strategy for cancer control address the issue of financial toxicity associated with cancer?
Good question.
This is Joe Lipscomb. They're pointing to me. First off, by doing an ever better job at documenting the level of financial toxicity, both in its overall magnitude and how it's distributed across the population, so as to bring ever stronger awareness about it, and also to try to carry out particular analyses that would look at the relationship between the nature of insurance coverage and the toxicity that flows, the financial toxicity that flows from it. The nature of the cancer plan reimbursement models that we see now being tested by CMS and elsewhere, and trying to understand what the implications are of those models are, not only for providers, but also, of course, for individuals and families, and making that clear and documenting it. The plan itself, is not aimed simply at reducing cost. It's aimed at providing the information and the structure that allows the relevant actors to work together and to try to move towards the ends that we think are important.
One of the biggest challenges in cancer control is the large volume of data coming from different sources. How would the National Cancer Control Strategy approach unifying different data sources and ensuring policy decisions are informed by the latest data?
Bill, do you want to get into that now? Joe?
Yeah, this is Joe Lipscomb. The plan itself did not provide a detailed blueprint for exactly what data are required or exactly how the data would be integrated. I mean, I think they see the plan itself sees that as one of the top agenda items for the actual conduct of of what we're recommending. In other words, once it gets moving, once it gets going, once HS convenes the public partners and the very important private partners, then the question about what data and how shall it be integrated becomes really, topic that's immediate. It's certainly essential in terms of building the planning and monitoring tool. There are challenges that are out there that we already know about. It's the challenges of linking registry data with claims data, particularly private claims data, which is an ongoing effort. We've had success in different parts of the cancer control system in doing that. We need a broader success. There's ongoing work to try to understand how to link the EHR data with various other types of outcomes data, and perhaps also with claims data. So the questions are already lurking in analyses that the various organizations are conducting now. Again, this is the question of if you bring the people together, can that help assist bring the data together?
The next question is, what is going to compel different players to come together in ways they haven't come together in the past? How is the incentive structure going to change?
Well, it seems to me that you want to use the framework of the complex adaptive system to drive that incentive structure. You want to be able to simulate that system and see the likely outcomes of alternative incentives. As we said earlier, one of the problems you have is that agents sometimes respond in unexpected ways, and something that you thought would incentivize behavior may disincentivize it. So you need to be able to experiment with this computational infrastructure to be able to see what incentives will work. Beyond the incentives part, I think the information sharing can be part of the incentive. In other words, financial incentives and information sharing, because the different players will value the information for better doing, serving their role. So they not only give information, they gain information. And I think that that can make a big difference. The other thing we've done in a variety of domains, aspects of health, is to provide in these models different views of the system. How is the patient seeing it? How is the provider seeing it? How is the payer seeing it? How is the supplier seeing it? And showing those views to each of the parties. And they begin to realize what each other party is facing, and they seem much more willing to cooperate then when they see how everybody else is seeing it.
Yes, Mary?
So this is Mary McCabe, and as I was thinking about Bill's comments and going back to this term financial toxicity, it was a term really coined because of the huge burden on patients and families during the period of diagnosis and treatment and follow-up care. But I think that one thing that we could say in bringing people together is that the cancer community, and by that I mean the large cancer community, has a financial toxicity problem in general. And so that should be, for each of the component parts, their own incentive to really begin to think about, are we spending our money well and in the right place? And that could be part of what convenes disparate groups to think that they have something in common.
This report proposes that the Department of Health and Human Services leads the plan. What other agencies should be involved?
Well, we explicitly identify, this is Dr. Johns, we explicitly identify those in the report. In fact, one of the slides that I projected listed all those agencies that are there, that are involved. And let's see, if you'd like, I can read them to you because it's quite a list. But so it's be led by the Department of Health and Human Services in cooperation with the Office of Management and Budget. This is the Department of Education, the Environmental Protection Agency, Department of Defense, Department of Veterans Affairs, Department of Housing and Urban Development, Department of Agriculture, Social Security Administration, Department of Labor, Department of Commerce, the Office of Personnel Management, Equal Employment Opportunity Commission, Department of Treasury, the Government Accountability Office would periodically review, and the Indian Health Service. That's a pretty extensive list. And you know, HHS oversees a lot of this activity, so that's why the logic of them being the convener and to bring them together. And I think there's a reason for them to come together when you look at the scope and scale of this problem that we've got to face as a nation and its impact on people's lives and their families' lives, but also on the economics, looking forward, 20 years out, and the impact it would have. I mean, talk about prevention. We need to get on this now. Prevent the outcome, the adverse outcomes that we could have for our economy and for our citizens.
Can you give us an example of a complex adaptive system at work and how that might play out in other industries where it's been more routine?
Well, I mean, we've applied this to studies and interventions in diabetes, heart disease, Alzheimer's, transition care of elderly patients. We've applied it to modeling higher education, where we use these tools to come up and evaluate alternative policies, evaluate the impact of alternative trends, of how the organization can cope with the trends. For example, the study completed just a year or so ago that Mike was part of on the transition care for the elderly, we were able to show with these models that the CMS's hospital readmission penalties just didn't make sense for almost every hospital in the country. It was not in their interest to comply with it. And why would you ever put a policy out when only 10 of 3,000 hospitals would comply? It's because they didn't understand the concept. It wasn't that the policy was unreasonable. They just hadn't projected the consequences of doing it. And once you began to look at it within the economics of each individual hospital, you began to realize why they would never choose to comply with this. So there's been a lot of instances with particular diseases, other domains. People have applied this in areas other than healthcare and education. We've been doing some work in transportation, like what's going to be the likely consequences of driverless cars? And can we understand different scenarios and how they might play out and what incentives would work? And so this is really not a new idea. It's probably a new idea in the scope that we're thinking about it. And we're not just looking at one intervention in a hospital, we're looking at all of cancer. So the scope is ambitious, but the concept is very well developed and has been used many times.
And this also is the notion of a complex adaptive system and how to manage it is used in the air traffic control system. Isn't that correct?
Yeah. I mean, we have more control over the players there than you do in cancer. But and physics controls a lot of what they can do too.
Yes, but it's a model, and weather forecasting is another model.
Yeah.
I suppose that weather forecasting is a little bit iffy still, but it certainly improves.
Well, there's also been some work on applying it to terrorism, where you look at how different groups are affected or disaffected and how they respond. This is a well-developed. I wrote my first paper on cancer as a complex adaptive system 20 years ago.
So if a complex adaptive systems approach is ultimately deployed, what new capabilities and competencies will be required of the cancer control workforce?
Okay, this is Mike Johns again. This is something we discussed in Chapter 4 in the report, so I'd reference you to read that very carefully. A complex adaptive system approach to cancer control does require a new set of capabilities and competencies, not just in analytics and policy makers, but also in many of those working across the continuum of cancer care. So it will require communication with a much broader range of participants than is existing today, and also the ability to understand and appreciate the goals and concerns of those working in other areas. And that's an important part, I think, about these complex adaptive systems is, that when you understand what you're doing and what its impact is on another part of the system, if it's an adverse impact, you can sit down and have a conversation about it and see how can you obviate that so you can get to where you want to get to. That benefits the system as a whole.
Another competency I think that fits in here is this is Bill Rouse, is visualization. Is how do you actually portray what's happening? How do you portray how consequences might propagate? This, of course, is a technology that is very hot in the U.S. now, that visualization, big data, et cetera, artificial intelligence. But we need to be leveraging all these technologies to pursue this complex adaptive system idea.
This is Ashley. I think one other competency will be need to be a broader competency with behavioral economics, understanding what motivates people, what incentivizes individuals in their workplaces, because often at an operational level, goals are set that are often very concrete, they're metric-based, but they can have unintended consequences, and leaders will need to understand, and decision makers will need to understand behavioral economic principles to implement this strategy.
We have time for one last question, and that is, cancer has been approached as a winnable war or moonshot. There's been discussion these terms are misapplied and don't fully capture the complexity of cancer. Can you explain?
Well, I think one good example for me, if you think about the goals we set out here and we get halfway there, that would be a tremendous boon to the country. Getting halfway to the moon isn't.
But along those lines, this is Ashley, the original moonshot, the Apollo moonshot, was a congressionally mandated, coordinated effort of 20 federal agencies.
Yeah, that's true.
So it is similar.
Good example.
Yeah, we need that. That's what we're suggesting, that we come together and succeed to arrive at the goals of controlling cancer in this country. And no one agency, one individual, one organization can do it by themselves.
Yeah. This is Joe Lipscomb. In that same vein, I mean, moonshot is, as often defined, it's setting the stage for a big accomplishment, and after that accomplishment of some finite amount of time, it's done, so forth. But what's being envisioned here is being able to think about cancer as a complex adaptive system in a way that learns over time, that continues over time. It doesn't stop. It keeps going, and the idea is to get better.
Well, it looks like those are all the questions we have time for today, and we had over 100 participants, so I apologize if we didn't have time to address your system, but again, to learn more about the committee or to download the report, you can visit www.naf.edu/cancer-control. And once you exit this webinar, you'll be directed to that report page. I'd like to thank our esteemed committee once again, and thank you all for participating and joining us today.